Good afternoon, and thank you for joining us for today's NILE webinar. This is Breanne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a few housekeeping items. First, if we should become disconnected for any reason, please call right back and we will continue. Second, please locate the chat box in the bottom left-hand corner of your screen. If you have any questions, type them in the chat box and we will address those questions throughout at the end of the presentation. Lastly, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended. CE certificates for nurses and pharmacists will be emailed out within the next week by Immunize Nevada. The post-event survey for CME will be emailed directly to physicians. Upon completion, those surveys will be given to the University of Nevada, Reno, who will be issuing them independently. Before we begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to the benefit of the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to our speaker, Kristen A. Feemster, the Medical Director of the Immunization Program and Acute Communicable Diseases at the Philadelphia Department of Public Health and Director of Research for the Vaccine Education Center at the Children's Hospital of Philadelphia. Thanks for joining us today, Dr. Feemster.
Thank you. Thank you very much for including me in your webinar series. I'm looking forward to talking about pertussis, its changing epidemiology, and some of the challenges to prevention that I think that many of us have confronted in recent years. We've certainly had some recent outbreaks, especially in school settings here in Philadelphia, and so we have been thinking quite a bit about optimal strategies for prevention and control. I have no conflicts of interest related to this content to disclose. And we'll focus today on four primary areas. First, we'll spend some time just reviewing the changing epidemiology of pertussis. It has shifted quite a bit in recent years. We'll also review clinical presentation. That's one of the things that I think has made it challenging to identify cases. Outbreak management, and then also key principles related to prevention. Pertussis, or whooping cough, just to review, is a respiratory tract infection. It's caused by a bacteria called Bordetella pertussis, and classically causes these paroxysms of cough that end in a characteristic whoop. And once you've heard someone with whooping cough, it is a sound you are not likely to forget. It is quite striking and was quite a common infection, a significant source of morbidity and mortality, especially amongst young children before the introduction of pertussis-containing vaccine in the 1940s, when there were more than 270,000 cases and 10,000 deaths per year. After introduction of the vaccine, you can see in this graph here, there was a significant and steady reduction in disease incidence with a nadir of a few thousand cases per year in the 1970s. And even with the reduction, though, there always has been kind of a cyclic increase every 3 to 5 years in pertussis, but overall sustained lower incidence until the 1980s, when we started to see increasing incidence, especially amongst young infants and adolescents. This really peaked in 2012 when there were about 48,000 cases. Our most recent year, when we have surveillance data available, 2018, there were over 15,000 cases, 5 deaths, with about a third of cases happening amongst adolescents ages 11 to 19 years. And even though the highest proportion was in this age group, it's really the highest incidence of both disease and hospitalization that occurs amongst infants under the age of 6 months. So pertussis does occur in all age groups, even though the risk is higher in certain age groups. And most importantly, when we think about our prevention strategies, disease is most severe in young infants who are too young to be fully vaccinated. And so an estimated 50 to 75% of infants who are infected will develop complications requiring hospitalization, so especially the youngest infants under the age of 2 months and younger, and about 1 in 100, or 1%, will die. And that's been a fairly consistent mortality rate just due to respiratory failure. So continues to be a potentially severe infection. So, one of the biggest changes that we have noticed with the epidemiology of pertussis, has been this shift in who is affected, and that has also influenced transmission and exposure risk. And so when you look at many cases, especially amongst infants, adolescent and adult contacts are often the reservoir for infection. And these are adolescents and adults who may have pertussis but have unrecognized disease because of atypical symptoms. And I'll talk a little bit more about that in the next few slides. So some recent surveillance data estimated that about 30% of infants with pertussis had actually been exposed to pertussis from their infected mother, and about 40% are infected from other family members. And so this table, again, of some of the more recent surveillance data that we have shows you the distribution of cases by age group. And so, again, we see a high proportion of reported cases that are occurring amongst adolescents and adults. So why are we seeing some of these changing trends? And there are lots of different reasons. A lot of this has been kind of a shift in susceptibility, and some of that is related to introduction of vaccine, as well as an important issue that I'll talk about later, and that is waning immunity after disease. Currently, the acellular pertussis vaccines. And there is also waning immunity actually after natural infection. So natural infection has not been shown to induce lifelong immunity when it comes to pertussis. But this is a nice diagram or figure from a Hewlett and Edwards New England Journal paper that shows this shift in the pre and post-vaccination era. So, before vaccination, pertussis really been a disease of childhood. So you have, children who get pertussis, they spread it to each other, and this through natural infection, they do remain immune generally through adolescence and adulthood, which can lead to transfer of protective antibodies to infants. And then as infants get older and those antibodies would go away, then you'd have more susceptibility in this kind of young children, amongst young children, and that's where you saw most of the disease. When it comes to the vaccination era, we've focused on making sure that we vaccinate infants, which is very important when considering, who gets the sickest from pertussis. And so you have protected infants, but over time, the immunity from vaccination can decrease. And so we are now seeing kind of a shift in more disease amongst children and adolescents, adults as well. And then they can then transmit to others in the household. So those are some of the reasons behind, changing epidemiology. Other things that have been attributed to some of the increases that we've seen in recent years also just related to more awareness, more frequent and higher case ascertainment, as well as availability of more sensitive diagnostic tests. And so that is also likely contributing to some of the shifts that we have seen as well. But again, pertussis is, it is in our communities, and now we are seeing it more in older kids and adolescents. So just to review clinical presentation next. So, pertussis, when we consider what it does and symptoms, is really largely related to a toxin that the bacteria produces. Pertussis is a toxin-mediated disease, and so the bacteria, it attaches to our respiratory cells, and it makes this toxin that paralyzes the little hairs or cilia on our cells that we need to help, clear bacteria and other irritants. And when they're paralyzed, it makes it really difficult to clear respiratory secretions, and the toxin also leads to some inflammation. And so because of all of that, you get up this paroxysmal cough because you can't clear your secretion. your secretions. So when we consider transmission of pertussis, it is a respiratory pathogen, so it is transmitted through large respiratory droplets. So when you cough, someone who's infected coughs or sneezes, they can spread the bacteria. There is an incubation period of about 9 to 10 days, but the range is up to 21 days, 6 to 21 days. And the important feature of pertussis to remember as well is that it really is highly contagious. It's one of the most contagious vaccine-preventable diseases. So about 90% of susceptible exposed household contacts will become infected. And if you have like a classroom of susceptible kids, in school, transmission rates can be 50 to 80% if you have kids who are fully susceptible. One of the reasons, just besides the properties of the bacteria, that pertussis is also kind of highly contagious is just that you can be contagious for a long period of time. And so you are contagious at the time of your initial symptom onset. So that's even your very first symptoms, even before you develop cough, and then you continue to shed the bacteria or be able to spread the bacteria for 3 weeks after your cough begins if you have not taken antibiotics. So again, pertussis does last a long time and spreads easily, and so infection does cover 3 stages. It's been called like the 100 days cough. It lasts a long time, and so it does start with a very non-specific upper respiratory syndrome that can last 1 to 2 weeks. The catarrhal stage, and again, even though this is very non-specific and you might not think that you have pertussis, you are able to spread pertussis at this time. The paroxysmal stage is when you have the severe cough, and that usually lasts anywhere from 1 to 6 weeks, but on average about 3 weeks. It can sometimes last longer. And again, you are contagious for 3 weeks into this paroxysmal stage. And then that is followed by a convalescent stage when you have a persistent non-paroxysmal cough that eventually disappears over several weeks. And so, symptoms last a long time, probably because of some of the toxins that are made by the bacteria. So you may stop shedding the bacteria after 3 weeks, but those are lasting effects of the pertussis toxin that can sometimes lead to these longer symptoms. So it is a very protracted illness. Because it is such a long illness, it can cause such severe, coughing fits. It is associated with, a lot of morbidity. It can be very distressing. And then there are also, some important complications to consider as well. But commonly, common symptoms, do include this paroxysmal cough and this whoop. On inspiration, really, you're just trying to catch your breath. You can have vomiting with coughing episodes, and especially in infants, apnea or pause in breathing, and which can be, of course, very distressing to observe. And sometimes that's the primary symptom in infants who may not present with the paroxysmal cough, but may just present with apnea. And I think for a clinical presentation, one of the really important things to remember what makes prevention and control challenging is that symptoms are not always typical, especially in vaccinated individuals. So you have older children or adolescents or adults who probably were vaccinated as children, but because immunity has started to decrease a little bit, they're able to be infected, they're susceptible again, but they have some protection such that their symptoms are not typical, they're probably milder, and they may just present with a prolonged cough, but not necessarily the severe coughing episodes or a whoop. So again, as I'd mentioned, there are important complications that can happen that can lead to hospitalization. So when you consider infants and children, as I mentioned, apnea is a major one. Pneumonia can also arise, sometimes related to a lack of oxygen from the coughing fits. You can see seizures, kind of inflammation of the brain or encephalopathy. That doesn't happen that commonly, but can occur. And then just from violent coughing fits, you can sometimes get a hernia. You can sometimes get even some bleeding around the your brain, or subdural bleeding, and a pneumothorax. which affects the lining around the lungs. For adolescents and adults, some of the complications, they may be less likely to be hospitalized, but they can have loss of bladder control because of coughing fits, fainting, sometimes even rib fractures, and then again, some of the other things that infants and children experience, a pneumothorax or hernias as well. And again, many of these complications really are related to the force of cough. So because many people, especially now when we have cases amongst older children and adolescents, can present with atypical symptoms, identifying cases can be a little more challenging. And so, there are certain criteria. So especially, from a surveillance perspective, when we're thinking about who might have pertussis, we think about clinical criteria, and these can sometimes help guide, potentially guide your thinking if you're seeing patients or children coming in with a prolonged cough. But the clinical criteria for a diagnosis include a cough illness of at least 2 weeks, along with one of the following classic symptoms, such as a paroxysm of cough, the whoop, or vomiting after a cough, or apnea. Laboratory criteria, of course, positive pertussis test, and I'll talk more about available tests in just a moment, and then an epidemiologic criteria in contact with a confirmed case. Those are all the things that are kind of considered, part of a case definition. But clinically, when you're really thinking about what to do, you're really going to consider a probable case or cough illness of any duration, especially if there's at least one clinical symptom and contact with a confirmed case. And then confirmed really is if you do have a positive lab test. So, generally speaking, we consider guidance that we give to clinicians when to suspect pertussis. Pertussis should be considered in any cough illness, and really doesn't have to be, more than 2 weeks of cough, but any cough illness, especially with no or with a mild fever. Pertussis is not typically associated with fever, and then especially if you have recent contact with someone else with known pertussis or a cough illness. And then also to just be even, I have a higher index of suspicion if a person presenting with prolonged cough illness has regular contact with infants or young children who are at risk for severe disease, because in that case, you want to make sure that you do identify pertussis quickly if it's there, so that you can start treatment and reduce the likelihood that they could spread it to others, especially others who are at high risk for getting really sick. And then we talked about identifying cases. Want to turn to diagnosis and management. Suspect pertussis, now want to do some testing. And so there are 3 general categories of diagnostic tests that are available for pertussis. They all have different kind of characteristics, and I would say different levels of utility that guide your clinical care and management decisions. PCR is probably the most important thing to do. PCR is the most sensitive and fastest test. It detects protein from living and dead bacteria, and it's very, very sensitive. It's very good at detecting little proteins from bacteria. And so it can detect the presence of pertussis for 3 weeks into illness. And so if you have somebody with a prolonged cough, they've been coughing for a week, PCR is still going to, should still give you a pretty accurate result. And it can even be positive for up to 7 days after starting antibiotics. Of course, antibiotics are going to kill the pertussis bacteria, but because you can still detect protein from dead bacteria, the PCR still works very, very well. Other things that we use less often, so culture, of course, it's bacteria. You can try to grow it, but this is something that takes time, and it's usually only going to work within the first 2 weeks of illness, meaning after you start a cough. And then the last test that you can sometimes do, especially if you have somebody that's presenting, more than 3 weeks maybe after they have gotten sick or started their cough, are serologies or antibodies. And those tests detect antibodies to pertussis. And so the important thing here is that it can be very difficult, of course, to interpret antibodies if you have somebody who's been vaccinated in the past. You know, we make antibodies when we get a vaccine, and so if you have someone who has a positive antibody test, that could be just because they have vaccine and not because they have a new pertussis infection. So a little bit harder to interpret those. So when you're thinking about what to do, and the key considerations, first, to make sure you get a very good sample. So if you are working in a clinical setting, you want to make sure you get a nose and a throat swab, a nasopharyngeal swab, and there are helpful tips on how to collect those available on the CDC's website. That will give you the best results. The PCR is a test of choice because it's fastest, most sensitive, and really the only time that you would maybe want to consider doing a culture is sometimes it can help confirm a diagnosis, and it just gives us more information about bacteria. So if you happen to be taking care of patients in an outbreak, for example, we would maybe ask to send a culture on from at least one patient. And then serologies, again, may be useful for patients who present really late in illness. But if you're going to send serologies, and this is something that you could talk to a health department about, you would want to make sure that you do tests that are from the CDC or a state public health laboratory, because those are the best ones and they're the most reliable. So testing kind of pitfalls. So really, really important to test people who have signs and symptoms of pertussis. If you test someone who does not have symptoms, so let's say you have somebody who's coming to your clinic and, they were exposed to pertussis in school, and maybe they have a little bit of a runny nose, and so you're like, okay, well, if I test them now, then, I'll maybe I can catch it before they develop the cough. A test result at that time is really not going to be reliable. You really want to test people who have a cough illness, and you really are worried about pertussis because of that. Because it's, again, not very reliable. You could either get a falsely positive or a false negative test. So really test on people who are symptomatic. Another thing to just consider, and this is something that I learned about after starting to manage or address pertussis outbreaks, is contamination can occur for the PCR test from pertussis vaccine. There's going to be a little bit of the proteins from pertussis in the vaccine, and so you don't want to process samples that you're sending for PCR and prepare vaccine in the same area, because that could give you a false positive. And then again, if you have someone who started antibiotics, your PCR test is not really going to work well after 5 days of the antibiotic use. So, we are diagnosing pertussis because this will guide management decisions. And really the big management decisions related to pertussis are going to be about treatment and then considering whether anyone might need post-exposure prophylaxis. So again, timely case identification, really important. It's important because it can help prevent complications if you can get somebody treated and also reduce the likelihood of ongoing transmission, really important for pertussis control. So early treatment can reduce the duration of symptoms, and it also can reduce the contagious period. And so your contagious period can decrease from 3 weeks to 5 days from the start of antibiotics. And so that's one of the reasons why early treatment is important. And then, again, for post-exposure prophylaxis, so sometimes it may be recommended that someone exposed to pertussis takes an antibiotic so that they don't, develop disease. And so that's important, again, for preventing complications in those who are really at risk for getting really sick from pertussis. And in this case, you want to make sure you start post-exposure prophylaxis within 21 days of exposure. So that's kind of within the incubation period. So who should be treated? So you want to treat suspected and confirmed cases while they still have active bacteria. So for kids who are 1 year, anyone over the age of 1 year, that's within 3 weeks of cough onset. After 3 weeks, then they're already done. They've cleared the infection themselves. They shouldn't have any living bacteria left. And then if you have an infant or someone who is pregnant, actually your period of time is a little bit longer. So infants and pregnant women, just because of how robust their immune response is, it's a little less robust against pertussis. They will shed the bacteria, or they'll be contagious for a longer period of time, so up to 6 weeks. And so for that reason, your treatment window is longer. Other people who you would want to start treating, so so I said treat suspected and confirmed cases. So in some instances, maybe you'll wait for a PCR, your test results. But sometimes, especially because early treatment is really important, for suspected cases, you're going to wait. You're not going to wait for test results, and you're going to begin treatment. And so for suspected cases who are at high risk for complications, or if they're in contact with high-risk persons, send the test, but go ahead and start treatment while you're waiting for the results. And again, as I mentioned, antibiotics are not effective if you start too late in the course of disease after the bacteria have already been taken care of or are already dead. So who should get post-exposure prophylaxis? This is a question we get quite often at the health department. And so recommendations, so even though pertussis is very contagious, and yes, it does have the potential to cause severe disease, but wide, large-scale post-exposure prophylaxis, like within a community setting, or even for a whole classroom, of school-age children, is probably not going to be the most effective approach necessarily for stopping an outbreak. So the CDC, actually, their recommendations for who should get post-exposure prophylaxis is more targeted on those who are at highest risk of severe disease, or for those persons who have close contact with high-risk individuals. So all household contacts of pertussis cases should get post-exposure prophylaxis, because your exposure risk is quite high in a household setting. And then anyone who's at high risk of severe disease themselves, or who have close contact with high-risk individuals, should get post-exposure prophylaxis. So infants, and so often like in a daycare class, if there are infants in that classroom, or pregnant women, especially in their third trimester, anyone who has chronic conditions that would be worsened or exacerbated by pertussis, so like somebody who has asthma, would have a harder time managing a pertussis infection, immunocompromised persons, of course, and then people who work in settings with high-risk individuals, including, who work with infants or who, provide care to pregnant women. You want to make sure that they receive post-exposure prophylaxis as well. But overall, CDC does not recommend that all exposed persons receive post-exposure prophylaxis, or that you do repeat courses of antibiotics if transmission is ongoing. So that question has come up a few times as well. If you have like a cluster of cases in a classroom, and you've given post-exposure prophylaxis, to really close contacts, and you're still getting some new cases, doing another round of antibiotics has not necessarily been shown to be an effective way to stop the outbreak. So repeat courses of antibiotics has not been recommended. So what are the treatment and post-exposure prophylaxis options? Really, azithromycin is the treatment of choice. Macrolides, but most commonly azithromycin. That's first-line therapy, a 5-day course. Azithromycin can be, given to persons across, all age groups, but there are some just important considerations for young infants. And so in really young infants under the age of 1 month, macrolides have been associated with a very small increased risk of something called pyloric stenosis. This is not a very common condition, but it is just something to consider. The risk is a little bit lower with azithromycin, so if you're going to treat a really young infant, use azithromycin, and that may be just something to counsel parents about to notice. But the benefits of treating are so important that this is the group where it's especially important to make sure that we're treating and providing a post-exposure prophylaxis. Trimethoprim sulfametazole can also be used. That's second line for anyone over the age of 2 months. One additional consideration related to azithromycin, this is something you may have heard about if you treat patients. But in 2013, I believe, there was an FDA warning posted about an association between azithromycin and heart rhythm abnormalities. And so this was based upon a study. They looked at patients who received azithromycin compared to other antibiotics, and especially among patients who were already at high risk for having heart problems. There was a very small difference, like 1 in every 21,000 prescriptions of having an arrhythmia. For those who were at low risk, the absolute difference was only like 1 in 100,000 prescriptions, so a very small additional risk. But the guidance is to just consider alternatives if you do have someone with known cardiovascular disease, especially if they have a condition that affects heart rhythm. So, what to do help? There's a pertussis outbreak at my school. So if you're, working in, a school setting or some other community setting, and you have pertussis case in a classroom or 2 cases, I think really the important considerations here, again, are doing what we can to just prevent ongoing transmission. So please call the health department, of course, because they can help with case investigation and provide guidance on post-exposure prophylaxis and symptom monitoring. And also, depending upon, whether any special testing is needed, can help coordinate testing. So when you have pertussis cases, again, to prevent transmission, they need to be isolated as long as they are able to shed the bacteria. So if they don't get antibiotics, that's 21 days from the time that their cough starts, or 5 days after starting antibiotics. So you're going to want to make sure that if you have a known case that they know that that's the that they'll need to stay home from school for 21 days if they haven't gotten antibiotics. For suspected pertussis, just making sure that they follow up with a provider for diagnosis and to start antibiotics if they need them. It will also, you may be called upon to help identify potential close contacts or people who might be at higher risk for getting sick who would need post-exposure prophylaxis. Always good to use this opportunity to check immunization records because being immunized is still an important part of prevention, and so good opportunity to check immunization records. And then I had already mentioned referring symptomatic students for testing. So just some key messages before we turn to prevention. Pertussis is highly contagious, occurs in all age groups. There have been shifts in epidemiology. Older children, adolescents, especially, a high proportion of cases do occur in these age groups, and it's older children, adolescents, and adults who've been previously vaccinated or infected are more likely to present with mild symptoms that can mimic other cough illnesses. Because again, as I mentioned, even natural infection does not necessarily confer lifelong immunity. So you can be susceptible to pertussis again. And then the last key message is that early recognition is important to prevent severe disease and to reduce ongoing transmission. So now turning to prevention. When it comes to prevention, really vaccination is our most effective tool. And I've mentioned waning immunity after vaccination a few times, and I will talk about the impact that that's had on some of the changes in epidemiology that we've seen. But vaccination does remain, even though there have been I'm concerned about waning immunity, the most effective tool that we have. Pertussis vaccines, just to provide a little bit of history. So again, as I mentioned at the very beginning, were introduced in the 40s, 1948 specifically, when we had a whole cell pertussis vaccine introduced. And so by whole cell, that essentially was like a killed bacteria vaccine. So it was a whole pertussis bacteria inactivated or killed. And that's what the first early vaccines were made from. And so these vaccines were quite effective, but because they were made from the whole kind of killed bacteria, they kind of contained a lot of what you call antigens. Those are the immune stimulating parts of a vaccine. And so they were pretty reactogenic. They were a fairly high rate of side effects. And over time, there was increasing amount of concern related to side effects in the whole cell pertussis vaccine. And now some of these side effects were things like high fever, excessive crying, as well. No side effects, resulted in any long-term or permanent. There were no permanent or long-term implications related to side effects, but they were difficult to tolerate in the short term. And they also gave rise to some general concerns about vaccine safety. In fact, there was a documentary in 1982 called Vaccine Roulette that focused on the whole cell pertussis vaccine and alleged that the vaccine can cause brain damage, and that the vaccine was unnecessarily dangerous. And so this led to the establishment of a group that has become the National Vaccine Information Center. It's a very well-organized, now well-organized anti-vaccine advocacy group, but also led to a lot of pushback against this vaccine as well, and some changes and developments in our vaccine safety infrastructure. But largely because of these safety concerns, a new acellular pertussis vaccines were developed, really to provide a vaccine that was less reactogenic and could be better tolerated. And so acellular pertussis vaccines were introduced in 1997 and have replaced the whole cell vaccine in many countries, though there are still some places that do, countries that use a whole cell vaccine. And so these vaccines are made from far fewer antigens. So, rather than like the whole bacteria, the vaccines are made after selecting about anywhere from 3 to 5, depending on the specific vaccine, purified specific antigens thought to be the most important ones to target for a good immune response. And so because you have fewer antigens to target, there are just fewer, it's not as reactogenic, there have been fewer side effects. And especially when the vaccines were first introduced, they showed a very good immune response and were effective for prevention of moderate to severe disease. But what we have observed over time is that the durability of immunity may not be very long lasting. And so you can see here, I just put up this graph again, that after the introduction of acellular pertussis vaccines, that is when we started to see increase in disease incidence. And so there have been a few studies over the past few years that have really examined the persistence of immunity after the acellular vaccine and do demonstrate that immunity can wane over time. And so this is just one study that looked at pertussis cases in some counties in California where there were some outbreaks and so high disease incidence, and the estimated vaccine effectiveness after getting your full DTaP schedule, and estimated that vaccine effectiveness really begins to decrease after 3 to 5 years. So after about 3 years, after you get your full 5-dose primary series, vaccine effectiveness is about is greater than 90% for the first 3 years, but by 5 years after completing the full series, declines to 71%. So, you will have increased susceptibility to being infected with pertussis if exposed. And then when you look at the response to Tdap, the durability of your immune response might be even shorter. And so it's estimated that antibody levels can start to decrease even within 1 year of Tdap receipt. Just some additional data. So this is another one, and I just included this one because this is looking at an outbreak in a child care facility. So this is amongst a group of younger kids who'd received, who had not yet had time to receive all 5 doses. So they'd completed the primary, they'd received at least 3 doses of DTaP. And so there was an outbreak in this child care facility affecting 26 of 117 kids and some staff members. And here it was just noted that the majority of affected kids had been vaccinated. And so this is one of the first reports of sustained transmission that could even occur in a setting with high vaccination rate, demonstrating, one, I think how contagious pertussis can be, but then also the potential impact of immunity that is not, is durable, is not very durable. And so, why have pertussis rates, increased since introduction of acellular vaccine? And so there's, because of these observations, of course, been focused on trying to understand why there may be less durable immunity. And I think we're still learning about, a little bit more about why we're seeing our current trends in pertussis disease incidence. Again, as I mentioned, some of it better awareness, testing, and reporting, but there have also been some questions about whether the bacteria itself might be changing a little bit, so that the that the antigens in the vaccine, do they all match the bacteria, especially for the pertussis toxin antigen, but it's not clear that that's really what's driving, the durability of immune response. There have also been some questions about whether the acellular vaccine just activates a different pathway, a different kind of immune response that might not be quite as long-lasting. And then also acellular vaccines, while they do offer good protection against infection, another way that the vaccines can have a really big impact on disease incidence is when they can prevent the likelihood that you, of the kind of carriage state. So, many of us carry bacteria in our nose, like a lot of us have the pneumococcus bacteria in our nose. And it's not making us sick, but we can still spread it to others. And the pneumococcal vaccine actually does get rid of carriage, and so that prevents our ability to spread it. But acellular vaccines may not do that, and so that probably affects its impact on disease incidence also. So lots of different reasons why. But whatever the reasons for declining incidence, this is our most effective prevention tool. And so even though we've seen these trends, I think it's very important to really remember and appreciate the impact of vaccination. And so if you do look at published reports of pertussis outbreaks, most cases are on or under vaccinated. And so, and if you look at unvaccinated children, for example, in a California outbreak, unvaccinated children were 8 times more likely to have pertussis than vaccinated children. So getting vaccinated is much better than not getting vaccinated. And then also there's just been quite a bit of work also just looking at exemption rates to school requirements that include acellular pertussis vaccines. And exemption rates, states that have higher exemption rates have been associated with higher pertussis rates as well. And just to highlight some of those recent studies, again, from a California outbreak, in areas where there are clusters of exemptions, 2.5 times more likely to be in a cluster of pertussis cases. And this has been identified in other counties as well. So vaccination does really matter despite the limits of our currently available vaccines. So, what I really like to emphasize is the importance of our current recommendations and ensuring that we implement our current recommendations, because this is really how we're going to maintain population-level immunity to prevent transmission and also to prevent disease amongst those who are at highest risk for getting very sick. So, I think related to our changing epidemiology, the recommendations for pertussis vaccination have changed over time as well. And so initially, really focusing on young children, and that still is the kind of foundation of our current recommendations. But we have a booster for 4 to 6-year-olds before they enter elementary school, and that's to ensure that they have kind of increased or strengthened immunity before entering school. The importance of making sure that we vaccinate 11 to 12-year-olds, and so that you are kind of boosting immunity amongst adolescents. And then really important newer recommendations to vaccinate pregnant women. And then, of course, making sure that adults get a Tdap booster as well. So I think really the current guidance is all about doing what we can to ensure population immunity. So if we know that vaccine effectiveness may decrease a little bit, all the more important to make sure we have really high immunization rates to prevent transmission. There are also catch-up schedules, and I just put this in here only because this is another thing we frequently are asked about, kind of catch-up schedules for pertussis containing vaccines, especially with, what to do about using Tdap for 7 to 10-year-olds. And I just put these resources here. If you have questions about catch-up schedules, it's quite complicated, honestly, and so I always refer to these job aids that are available on the CDC website. So just a few DTaP details. There are quite a few different vaccines available here in the U.S., 6 different ones, and their efficacy after the 5-dose series within 1 year, it is quite high, 98%, and I told you what it was after 5 years, that it does decrease 71%, but that's still 71%. And DTaP, the acellular pertussis vaccine, is well tolerated. Contraindications really are history of severe allergic reaction. This is the same for any vaccine. There's also a contraindication if you have somebody who developed an encephalopathy within a week after a prior pertussis vaccine dose. So this is something that had been reported after the whole cell pertussis vaccine in particular. And so if there's any history of this, that would count as a contraindication to getting DTaP. Otherwise, side effects, known side effects that can happen are mostly kind of localized side effects, and precautions for vaccination. And these are also questions that sometimes come up for DTaP in particular, but concern about whether DTaP can make a seizure disorder any worse. And so if one does have a history of seizures or a progressive neurologic disorder, if that person's seizure disorder is under good control, then you can vaccinate. But if not under good control, you can defer until the condition is stable. And then history of some of those symptoms or of concern after the whole cell pertussis vaccine as well. If those have ever been reported, that can be considered a precaution. Tdap also, that was introduced in 2005. There are 2 available vaccines. Overall efficacy is to 73% 1 year after vaccination, but can decline as low as 34% 4 years after vaccination. So Tdap, important for adolescents, catching up 7 to 10-year-olds, and to give to adults. And precautions and the contraindications similar to DTaP. The only difference I would say is if there's a history of what you call an arthritis reaction or significant swelling after a tetanus-containing vaccine. Those are really the only differences, but again, well tolerated. And one important thing to note is that the adult Tdap dose can be given regardless of time interval since the prior, tetanus booster. You don't need to wait, 5 to 10 years if they've never received Tdap. There have also been a few other important changes to recommendations that were just approved by the ACIP late in 2019. So the first is that catch-up schedule for 7 to 10-year-olds in particular, when you're using Tdap, must contain at least 1 Tdap dose. But for all subsequent doses, so let's say they need 3 doses to be caught up, you can use either the tetanus diphtheria or Tdap for each dose. And then if you have an adult and they are due for a tetanus booster, you can use either tetanus booster or Tdap, regardless of whether they've already received Tdap. Essentially just saying you can use whatever you have available. And so an important change to recommendations. As I'd mentioned, one of the really, really important changes to recommendations to ensure that we're protecting our highest risk persons, infants, is immunizing pregnant women. And so the current recommendations do state that all pregnant women should receive Tdap during the late 2nd or 3rd trimester of each pregnancy. And so an important recommendation. And Tdap may be given postpartum if they've never received Tdap before. But really, for the greatest effectiveness, getting vaccinated during pregnancy is important. And so why vaccinate during pregnancy? this is really about being able to share maternal antibodies to ensure that a baby is, as soon as they're born, they have protection. And so a mom passes her antibodies through the placenta, during pregnancy, and this really increases towards the end of a pregnancy. And certain types of antibodies can be even higher in newborns than in mothers. And so it's a great opportunity to share protective antibodies with an infant, especially before they'd have an opportunity for protection through vaccination. And there have been studies to show that vaccinating during pregnancy can prevent 78% of cases and 90% of hospitalizations in infants less than 2 months of age. And so, why are we doing this in every pregnancy? And so, that really is because of waning immunity. So I showed you that immunity does decrease very rapidly for Tdap in particular. So if you've gotten a dose in one pregnancy, that's probably not going to give you, a lot of circulating antibody to share with your, a baby in your next pregnancy. So, one dose will not provide sufficient protection for subsequent pregnancies. And so that's really why vaccinating every pregnancy. And repeat vaccination during each pregnancy has also been shown to be safe. And so, of course, this was a consideration before making this recommendation. And, most women who have more than one pregnancy, do have an interval of more than a year as well. So what about safety and giving Tdap during pregnancy? So this can be done safely. One, Tdap is an inactivated vaccine, and those can generally be received safely during pregnancy. There was a review of safety data from receipt of Tdap during pregnancy, or the receipt of Tdap or tetanus vaccines as well, or getting tetanus toxoid during pregnancy. And so, all of this information was reviewed. And then there have also just been some, studies looking for any potential safety events now that this recommendation's been in place. And there have been reports of fever, achiness, and, swelling, local reactions, but no severe adverse events attributable to vaccination have been reported. There is a theoretical risk for more severe local reactions whenever just because the vaccine, especially if you have closely spaced pregnancies, just because your doses are given with a shorter amount of time in between them. But besides those local reactions, no severe adverse events. So those are the recommendations for pregnant women. I think the other big question that that often arise are related to vaccinating healthcare workers and older adults who are close contacts of infants. So again, every adult needs to get a Tdap if they haven't gotten one in the past, and healthcare workers especially need to get Tdap because we are more likely to have contact with high-risk persons. But there has not been kind of a blanket recommendation to revaccinate healthcare workers, even though we know that immunity after Tdap receipt does decrease. And so the current recommendation is for one booster dose. However, you can consider revaccination if there's a suspected or documented, if you're working in a setting where there is a pertussis outbreak or that there has been some transmission. That is one time when you might consider revaccination as a way to help prevent ongoing transmission. Other big thing is, especially for occupational exposures, is no matter when you've been vaccinated, that really does not replace the need for post-exposure prophylaxis if you have been exposed to pertussis. And so, reasons for not implementing a blanket revaccination recommendation, again, is that it's not clear how well it would work to give additional doses to prevent transmission. And so, again, really just to do it if or consider it if you do have, a few cases or you're worried about active transmission. And then also just, really thinking about how this might impact kind of protection if in a group. Again, as I think I'd mentioned, the vaccine is not one that's going to prevent carriage. And so, for all of these reasons, I think trying to really focus on protecting those who are at highest risk has really been the focus of recommendations. So for the last few slides, just going to talk about vaccination rates and how we are doing. So overall for DTaP, if we look at young children, immunization rates nationally are quite high. So for entering kindergartners, at least this is amongst the sample of kindergartners, rates are about 95%. And DTaP is often required for school entry, which is probably supporting these high immunization rates. If you look at younger children, those who have gotten at least 3 doses, 93%. Though series completion, that 4th vaccine dose, is a little more challenging, 71%. That's certainly one we have had a challenge with in our jurisdiction. If you consider, the successes we've had with implementing cocooning and making sure we get pregnant women vaccinated, at least among some recent survey samples, about 55% of pregnant women did report that they received Tdap during pregnancy, though there are pretty significant disparities by race, education, marital status. If you look at adults overall, only about a quarter report having received a Tdap. So definitely have room for improvement in making sure that all adults get at least 1 Tdap. But rates a little bit higher if they do reside with a young infant, and about 50% of healthcare professionals have reported receiving Tdap as well. At least these are just based upon like national health interview studies. And this is a very busy graph showing the most recently available data, at least, so you can kind of see where Tdap sits compared to some other vaccines recommended for adults. So there certainly are challenges, I think, when we're considering how to make sure we get, especially adults, vaccinated. For young children and adolescents, requirements really help. Even for 11 to 12-year-olds, many school jurisdictions require that middle school students receive Tdap. But we don't have similar requirements, of course, for adults. And so barriers do include lack of recommendations. So pregnant women who say they're vaccinated are most likely to get vaccinated if their provider recommended it for them or had vaccine available. And then access to vaccine as well, reimbursement questions, another important barrier. So changes that have helped improve coverage for adult vaccines, coverage of adult vaccines in registries so you can identify who needs Tdap, alternative locations, pharmacies, retail clinics as immunization providers can be important as well. So hopefully we'll continue to see rates increase so that we can do what we can to really optimize the use of our current vaccines. I don't have a specific slide about this, but sometimes we'll get a question about whether there are any new vaccines under development that might work a little bit better, or what should we bring back a whole cell pertussis vaccine. I don't think that would happen just because of its side effect profile. And so I don't know of the vaccines that are imminently going to be available, new pertussis vaccines imminently available, but there are some kind of in the pipeline. I just read an article today about I believe it's an intranasal pertussis vaccine that has promising early results, and so maybe eventually there will be a more effective pertussis vaccine available. But until then, I think important to again optimize use of this tool that we have, because it does remain our most effective tool for the prevention of disease, especially in high-risk persons, and to try to prevent transmission as much as possible for the pertussis that might be circulating in our communities. So here are some resources, infographics for patient education, other resources for kind of answering questions. And thank you very much. I'm happy to answer questions.
Perfect. Thank you so much, Dr. Feimster. Before we say goodbye, we'd like to offer a little more time for last-minute questions, so please type those questions in the Ask a Question box on the left-hand corner of your screen now. While we're waiting for those questions to be typed in, just a couple of reminders. If you have requested continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended for nursing and pharmacy attendees, and sent via email for all CME credit seekers. Nursing and pharmacy CE certificates will be mailed out within the next week, and and completed post-surveys for physicians will be passed along to the University of Nevada, Reno, who will then issue those certificates independently. Also, if you'd like to review or share this webinar or view any of our previous webinars or presentations, the recordings are available on the Immunize Nevada website. This one specifically will be up within a week's time, along with information for future webinars. And that is on immunizenevada.org/webinars for those details. So there's quite a few questions that are kind of in the same vein. So you talked about cocooning. We're right at the 1:30 hour now, so we'll address a couple of these. So cocooning, we talked about immunizing pregnant moms, but that also involves immunizing immediate family members, husbands, and those folks as well, correct?
Well, that is one aspect of cocooning, especially, every adult. The recommendation is that all adults receive one dose of Tdap if they have not received Tdap as an adolescent, if they've never gotten Tdap before. And to especially make sure you get one if you do have contact with an infant. But there is not a recommendation that all infant caregivers, that they get a repeat vaccine. So let's say you're in a home that, the father of, gets vaccinated for every child that's born. The repeat vaccination for Tdap is for pregnant women. And there are a lot of questions about, why that is the case if you want to kind of make a ring of protection. And I think really the rationale for the current recommendations is that through maternal vaccination, that is how you provide the kind of best and most direct protection to young infants when they are at highest risk, within those first 2 months. That's the most effective way for protection. And so this is not to say that that your spouse couldn't decide to go get. Certainly he'll need a Tdap that the spouse will need a Tdap if they've never gotten one. But the focus really is on making sure that pregnant women are vaccinated each time. And I see the questions about if immunity wanes over time. Why do we suggest a Tdap booster every 10 years? Really, it's not a Tdap booster that's recommended every 10 years. It's a tetanus booster. And so, and your immunity for tetanus is going to last a little bit longer. And you really only need one Tdap booster. But as I had mentioned, the ACIP did just say that if you were due for a tetanus booster and you go to a pharmacy to get it and they only have Tdap or your provider only has Tdap, you could get you could get a Tdap at that time. And we will hope that recommendation may make it easy, make it easier to, get if you happen to get a second Tdap, to make sure that it's covered. But there isn't a blanket recommendation for, everyone to get a Tdap every 10 years.
Yeah, and we saw quite a few questions kind of surrounding that general vein, and I think you answered too about not having to get immunized aside from mom having to get immunized during every pregnancy. So I think that was addressed. There was one other question talking about specifically healthcare providers, and you talked about revaccination in the healthcare setting. I think you addressed this for the most part, but there was an add-on to the question that asked is because their facility doesn't offer an individual dose of tetanus, is it harmful to get Tdap in place of that individual tetanus vaccine? But you would address that too as far as the ACIP recommendation.
Exactly. And, generally speaking, even if you were to get it's like, let's say you'd gotten a tetanus booster 2 years ago, and you're like, oh no, I have not gotten a Tdap yet. I'm going to get a Tdap now. There's no minimum interval. You can get that Tdap now. That can be done safely. That's part of the current recommendation. I think that the biggest consideration for getting vaccines more closely spaced might just be you might be more likely to have a little more of a local reaction, but otherwise that can be that's well tolerated.
Right. Well, great. I know that there were a few other questions both in the Q&A section and the audience chat that we did not get to during this presentation. We will go ahead and forward those or answer those ourselves when at the conclusion of this presentation, so that Dr. Feimster or Immunize Nevada staff can answer those questions for you. That concludes today's NILE webinar. Again, thank you, Dr. Feimster, and for those of you who were able to participate today. Have a great day.
Thank you. Thank you very much.